So we're now going to cover a very common clinical scenario, and that's the patient with a lumbar disc prolapse. So about 2 months ago, Tom was digging in the garden and he felt a sudden onset of severe pain in the lower part of his back, and it kind of felt like something snapping. It was really one of the worst pains he'd ever had in his back. He doesn't usually get back pain, and he took himself back inside the house and found that the only really comfortable position was lying on the couch or on the floor. He rested like that over a couple of days and then noticed over the next week a gradual and progressive onset of pain radiating from the spine down through the buttock, down the back of the leg, down through the back of the calf and into the outside of the foot. You also noticed that any sort of movement, particularly standing or walking, would make the pain worse and would often produce painful paresthesia, tingling in the distribution of the sciatic nerve. So he saw his general practitioner who prescribed some strong analgesics and advised Tom to rest, which was very sensible advice, because when you have a combination of back and leg pain, activity often makes the pain worse. In the second week, he then went to see a physiotherapist, and what Tom found, and the physiotherapist was very good at relieving some of the pain in his back, but unfortunately whenever he tried to undertake any of the exercises that she recommended, it made the pain in his leg worse. So the GP suspected a lumbar disc prolapse and so referred Tom up for specialist advice. And when I saw Tom, I examined him and this is what we found. So we start off by looking at the back. And you can see that Tom is slightly tilted over to the side. And this is a finding that occurs because of asymmetry in the muscle spasm. Now sometimes the curve is towards the side of the affected leg, but paradoxically sometimes it's opposite to the affected leg. And this sort of curvature, which is due to muscle spasm, often disappears when the patient bends forwards. The trouble here, of course, is that Tom is very reluctant to move his back because any movement makes the pain worse. But we'll try and look at some of these movements. So can you bend forwards, Tom, and see if you can move forwards to... And you can see that he's very, very limited, both in forward flexion. And can you try and bend yourself backwards now? And again, he's doing that, but it's very painful and making the pain worse both in his back and down the leg. We'll just try and see if we can do any lateral flexion, so he can tilt over to the side, and he'll do a little bit of that for us, but again, movements are very restricted, and then move over to the left, and again, the movements here are very restricted. So, Tom, if you come turn around and face me now. So the quickest way to test for whether there's any weakness is to get Tom to stand up on his tiptoes, and what we'll find is that there is some weakness of plantar flexion in the right foot, and that when he tries to stand up on tiptoes on the right side, I think he'll find that very difficult. But let's see how we get on. So we go up on both feet to start with, and he can just about manage that. Now if you could stand on your good foot now, Tom, I'll hold you for balance, and then go up on your tiptoes. So he has normal power of plantar flexion in the left foot, okay, and then on the right foot, try and stand up. And he can't do it. And so that's a very good test for a very subtle degree of weakness of plantar flexion. And then if you just lift your foot one at a time, lift your good foot first, and we're expecting the power here to be normal, and your right foot comes up normally, so that's absolutely fine. So the distribution of pain that Tom's describing is coming down through the buttock, through the back of his thigh, just turn slightly to that way, back of his thigh, down through the calf and to the outside of the foot. And the pins and needles and numbness he's also getting in the same distribution. And this is very helpful because he's marking out a dermatomal distribution of pain, which is in the distribution of the S1 nerve root. Okay, so if you'd like to lie on the couch for me, if you can find your way over there. He's a bit stiff in all his movements. And what I often find is a good test for patients who do have severe leg pain is you ask them to take their socks off and they can't do it. And we have to get their partner or the nurse, if you have someone helping you, to do it for them. So when we come to examine the leg, the most important physical findings are going to be a limited straight leg raise, which will reflect tension on one of the nerve roots going to make up the sciatic nerve. So before doing the straight leg raise, we'll just make sure that the hip is okay. So he'll be able to, the hip movement should be normal. So you keep the leg bent, move it up very slowly, it can be painful. Lift the leg up and then just check a bit of internal and external rotation of the hip, and that hip is moving fine. So any restriction that we find in straight leg raise will be a consequence of nerve root tension. Bring it down, and sometimes lowering the leg can be painful, so you need to be very careful in patients with severe leg pain. Okay, so we'll try and do a straight leg raise. We'll lift the leg up straight, and Tom, please tell me if this hurts and when you've had enough.
Yeah, it's starting to hurt.
And can you just tell me where that brings on the pain?
Down the back of my leg.
All the way down the back?
Yeah.
And is that the sort of pain that you've been getting with this over the last few weeks? And does that cause a bit of pain in your back as well?
Yeah.
Okay. And then if we dorsiflex the ankle, do this very gently because this is likely to make his pain worse. Yeah. So that test is very positive. So we'll just lower the leg down very carefully and check the reflexes. So being an S1 problem, we're expecting to find the ankle reflex depressed and the knee reflex should be normal. So we'll start with the knee reflex. And Tom hasn't got great reflexes, so I can see the quadriceps contracting there. Then we go to the ankle reflex. And there's just a little flicker of a reflex there at the ankle. Okay, let's put the leg back. And then in testing the dermatomes, we're expecting to find some alteration in pinprick in the S1 dermatome. So I've got the pin here. I'll start where I think it's going to be normal in L4. Do you feel that is a normal pin? Then in L5, which is going to the big toe, sorry. And then, what about over here? Does that feel a bit numb?
Yeah.
So if I compare it with that,
Yeah.
and what about if we compare it with the other side? Sharp there?
Yeah.
Yeah. And in this region of the S1 dermatome, there's a loss of pinprick sensation. So Tom has a classical history for a lumbar disc prolapse, an injury which causes pain in the back to start with, and then developing leg pain over the next few days after the initial injury. The natural history of a lumbar disc prolapse causing back pain and sciatica is usually very favourable. Most patients will recover, provided they are patient and are prepared to wait. By 6 weeks, roughly 50% of patients will have made a full recovery. By 3 months, 70% of patients will have made a full recovery, and by a year, 95% of patients. But for those patients who've got severe pain, which has been going on for longer than 4 to 6 weeks, with no signs of recovery, patients who are unable to work because of their symptoms, then we need to consider alternatives to conservative treatments. And the main alternatives are either a nerve root injection or surgery. And surgery for lumbar disc prolapse is a very good option. The surgery is safe, it's effective. We can perform the surgery as a day case. Patients come in on the day of surgery, and the surgery, the disc operation, is done through a very small 2 centimetre incision on the back. After the operation, patients get out of bed 2 hours later, and provided they're comfortable, we let them go home 6 hours following the surgery. The vast majority of patients undergoing this type of surgery will get immediate relief of leg pain, and by 3 months, 95% of patients will have complete relief of the pain in their leg. And what we find is that when we cure the leg pain in most patients, we also significantly improve the back symptoms.